But let me begin by saying that I first bring greetings from my institution, St. John's Medical College. And these are some of the activities that we do in our institution. We call it the Senior Citizen Health Service, which is one of the programs of the Department of Community Health at St. John's Medical College. We do these things, we've been doing these things over the years. We conduct rural geriatric clinics in about 8 or 9 village locations once a month in rotation, where we see elder people in villages. In fact, Dr. Rock and Dr. Neetu have been part of that program. We also conduct a home health service where a doctor and a nurse visit people at home who have registered with us once a month, just to give them a checkup to see how they're doing and to see if there is something new which we can pick up. We visit 3 old age homes which are run by missionary sisters once every month, just to see the residents and how they're doing at the old age homes. And very recently, we've started this, which is called the Grama Hiriyara Kendra. Grama Hiriyara Kendra in Kannada means Village Senior Center. For a long time, we've been looking at Anganwadi Kendras, which are centers in villages where children 0 to 6 come in the morning. Mother leaves them there, mother takes them back in the afternoon. And we were thinking to ourselves, why can't we have a center like that for elderly people in the village? So in 2 villages we have started these village senior centers where elder people come at about 9:30, 10 in the morning, they stay during the day and they go back in the afternoon. So this is who we are and this is what we do. And we've been doing this now for the past 15 years. The Senior Citizen Health Service got formally inaugurated in the year 2005. And it is from what we have seen and learned from this program that I now stand here with the confidence that I can speak to you something that we know about the health of the elderly. So let me start with 5 things about elderly people and the population of the elderly in our country that perhaps you know or perhaps you would like to know. First, the elderly population in our country is large. Well, the population in our country is large. Anything in our country is large. So it stands to reason that the proportion or the number of people above the age of 60 in our country is huge. Now this is a graphic which shows the growth of the elder population. And this is according to the 2011 census. We have a census coming up next year. And when we count the elders next year, I am sure that this number is going to reach about 120 or 130 million. 130 million. Just think of that number for a moment. 1 million people is 1,000 people. And we have 130 million elders in our country. That is more than the entire population of the United Kingdom, Australia, New Zealand, and a few European countries put together. And that's just senior citizens in our country. So we have a large number of seniors. Not only that number is large, but if you look at the percent of seniors in the population, in other words, the proportion of the elderly in the population, that also is growing. It was 5.6% in 1961. It is 8.6% in 2011. And we anticipate that by the time we are in 2050, which is 30 years from now, which is when you will probably be at the prime of your practice, the proportion of older people is almost 1/5 of the population. Just think about that. You see 100 people, 20 of them will be elderly. You see 5 people, 1 of them will be elderly. Now that's a tremendous number. So not only do we have a large population of seniors, but that population is growing. The next thing we know is just like with the rest of the Indian population, most of our seniors live in the rural area. Now we know that our Indian population itself has about 69% urban and 69% rural and 31% urban. That percentage is slightly larger with the elderly. So we have what we call the phenomenon of the ruralization of the senior population, where we have most elderly people living in villages. Third, the elderly population is what we call heterogeneous. Now what does that mean? Now look at this. This is a class of children. Now you know, when you enter a class of children, I'm sure all of you have walked into a village, into a primary school or an Anganwadi Kendra, and you go inside and all the children, they all get up and they all say good morning or hello sir or whatever it is. They all appear similar. Right? But when you follow that group up to the age of 65 or 70, you see that they become completely different from each other. Some of them are healthy, some of them are depressed, some of them are diabetic, some of them can walk, some of them can't. In other words, do not think that all elderly persons of a particular age are similar. They are not. Each one is unique. And that is the phenomenon we call heterogeneity in the elderly. Fourth, within this large pool of elderly people, if I were to pick one subgroup which I feel deserves our attention even more, that would be the single elderly woman. Now look at this statistic. Among older men, among the elderly men, 18% are currently single. In other words, their wife is no longer alive. But among older women, almost half are single. Right? So if you look at the population of elder women, the population of single elder women is a substantial chunk of the population of elderly women. And I think that if we are to do something for elderly people, if we were to start a program for elderly people, we have to prioritize the single elderly woman. Also because almost 3/4 of the elderly are either fully or partially dependent, but that proportion is even higher for women, obviously, compared to men. Right? So we have a large population, we have a growing population, we have a largely rural population, we have a heterogeneous population, and in that population, the single elderly woman is of particular importance because she is an area of priority. And the fifth thing that I would like to present to you is that if you look at the physical, mental and social well-being of the elderly, I'm using the WHO definition of health. In other words, I'm asking the question, is our elderly population healthy? If you look at the physical, mental and social well-being of the elderly, you see that it is not exactly a beautiful picture. Now, the prevalence of acute and chronic morbidity, that means an acute sickness or chronic sickness, as a percentage, you see that it ranges between 30 to 37% as acute at any given point in time, and 40 to 65% chronic morbidity. That means any chronic disease. It could range from diabetes and hypertension to osteoarthritis to eye problems, whatever. And the prevalence of psychological distress is almost half. In other words, it's a large, it's a growing, it's a predominantly rural, it's a heterogeneous population, and that population has problems. Now, our setting, and when I say our setting, I mean those of us who work in the community, our setting is largely primary care. And when you sit in a primary care clinic and see an older person, what are some important characteristics of the elderly presenting to primary care that you need to know? That's our next question. Here are 5 important characteristics. I'm using the term 5 just so that you can take something away from this session. You can remember that there are 5 important demographic characteristics of the elderly. Large, growing, rural, heterogeneous, single elderly woman, and problems. Prevalence of problems. Right? And if we were to look at characteristics of elderly people presenting to primary care, Again, I am presenting 5 characteristics. First, elderly people with health problems do not present early. Now, what's our teaching to our community? When you have a problem, please come forward and report it. But elderly people don't. Why not? Because first, they feel and they have been told, you are old. You will have some little pain, this, that. What do you expect? Do you think you are 20 years old? So they feel that, okay, I have a problem, but it is natural. I mean, old people will have problems. Right? And that view is an ageist view. What is ageism? Discrimination on the basis of race is what we call racism. Discrimination on the basis of age is what we call ageism. Right? When we treat somebody different just because he's an older person. Right? Second, poor faith. What will they do? I am already 60, I'm 65, or 80, or 75. I have this problem. What can they do? Forget it. There's no point in going. And that is another reason why elderly people don't present early to healthcare. Access. I want to go, but how can I go? Who is there to take me? The bus only comes twice to our village. Difficult for me to get into that bus by myself. So it could be geographic access, transport access, whatever. Right? Poor access. And of course, the psychological state of mind itself. These are reasons why elderly people do not present early to primary care. Second, they require what we call more physician time and continuity of care. In fact, Dr. Bijan also was speaking to us about the importance of follow-up with elderly people. We need continuity of care. There's no point in seeing one person once and feeling that we have done it. No, you have to have continuity. And why do we have to have continuity? Because elderly people generally don't have just one problem. They have more than one problem. They have issues with communication. Maybe they have not understood what you have said. They have not heard what you have said. Their presentations are not typical. Like I often tell my younger students, pneumonia in a young person, we are taught, if you look at your medicine textbook and your pathology textbook, you say that a person with pneumonia is supposed to present with high fever, tachypnea, rusty colored sputum and cough. But we all know that in an elderly person, that may not be the case. He may say there is a little, I'm feeling a little odd today. I have a little pain in my back. Right? And that could be the beginnings of a lower respiratory infection in an elderly person. So the presentation may not be typical. We need to look, therefore, comprehensively at an older person, which I will speak about shortly. We need to involve the caregivers of elderly people. It's not just looking at a patient, seeing him, giving a tablet and telling him to go. Who is looking after me? Who do you live with? Do they know? Can you please call them? Let me tell them also. Right? And follow-up and continuity, like I said, are very important. Third, elderly people require some senior-friendly health facility. Now, this is a quotation from a person at a teaching college hospital. Crowded OPD, narrow corridor built for the fast and the furious, no toilet within a 5-kilometer radius, tired leg, long lines at the pharmacy and registration. Now, how often we have seen this kind of a picture in our teaching hospitals? I'm sure this one, on the other hand, is built beautifully. But if you go to a more crowded kind of an environment, you see many of our facilities are not necessarily friendly to the elderly population. Right? So they need senior-friendly health facilities. They require a multidisciplinary approach. We talk about 2 types of cooperation, horizontal and vertical. Horizontal cooperation is with others at that same setting. Primary care itself, can we have a physiotherapist? Can we have a counselor? Can we have a nurse at the same level? And let's all deal with this elderly person. Vertical cooperation is when you go to the next level, with maybe a specialist, a super specialist. You have a good referral system, right? So they require a multidisciplinary approach and, of course, for those of us who are working in the private sector, elderly people need a careful consideration of the cost of care. Because you know that care and therapy for elderly people is likely to be lifelong. It's not that we can give them a paracetamol tablet for 5 days and hope that all is well. It won't. Right? So we know that therapy is lifelong, care is lifelong, and therefore cost of care is a very, very important determinant of the health of the elderly. So these are 5 things that we must keep in mind when we speak about the characteristics of elderly people in primary care. Right? So we've thus far spoken about 2 things. 5 important demographic considerations about elderly people. The population is large, growing, rural, single elderly woman, and the heterogeneity of the population in terms of dissimilar groups and the prevalence of acute and chronic morbidity. And of course, the 5 characteristics of elderly people who present to primary care. Now let me give you this situation and see how we will work with this situation. An elderly person from this large growing population that we speak of walks into a primary care clinic. It could be a primary health center, it could be a rural health center, it could be any facility where the first contact is with you. Your setting is primary care, and my question is, an elderly person walks into your clinic, what will you do? So now this is what my next segment of what I'm going to speak about is, which is how do we comprehensively look at an older person? So for this, I would like all of you to welcome Mr. Manik. Sir, very glad. On behalf of all of you, I welcome Mr. Manikam onto stage. He has very kindly agreed to be present with us and to help us out with this session. So on behalf of the organizers, Mr. Manikam, Romba, thank you here for giving us this opportunity. So Mr. Manikam is a 75-year-old gentleman. He is from the neighborhood, and his main chronic issues are that he has hypertension, but hypertension for which he takes a tablet every day. He also has a suggestion of osteoarthritis in his knees, a little bit of knee pain. There is a past history that says no past history, but there is a past history of hospitalization for a urinary complaint, but otherwise no major past history of hospitalization. His daughter is diabetic, and his wife also, who lives with him, has diabetes and hypertension. And his personal history seems unremarkable. His bowel, bladder habits are normal, sleep and appetite is okay, he doesn't consume tobacco or alcohol. Right? And on examination, as you can very well see, he is conscious, alert, responsive. He doesn't appear in any distress. And his blood pressure reading, the last one, was about 140 or 150 over 70 sitting. His heart rate is 72 per minute. No other really significant findings on physical exam. So when such a person comes to you, you would perhaps assess him, and you would say that you have identified these 2 problems. He's not a known diabetic. So he has hypertension, he has osteoarthritis, and he's put or continuing the medication that he's taking, which is telmisartan 440 milligrams and hydrochlorothiazide 12.5 with the tablet called Telma H once a day. And he is in fact practicing a little exercise to strengthen his quadriceps muscles, to help with the osteoarthritis. Now, this is what would typically happen at primary care when a person like this comes. So these are his medical ailments. But we know from what we have discussed so far that elderly people don't necessarily have just one thing. They have many things. There is a link between their physical illness and social condition. Maybe there is an atypical or non-specific presentation, and maybe there is an underreporting of disease. And the aim of geriatric medicine, this conference is on community geriatrics. The aim of the care of the elderly is that we want to restore their functional capacity and promote independence for the greatest time possible with the best quality of life. That is what we are here to do for the elderly. So it's not necessarily cure, but trying to maintain functional independence and quality of life for the longest period. Right? So keeping this in mind, let us look at him again. But this time, let us use a little comprehensive approach. And we will assess him again, including the following things. We will look at his medical status, which we have just done. That is the part which we did just now. But we will also look at his physical, functional, mental health, and social status. Because, like I said, we want to look at him comprehensively. Now, if we go one by one, his functional or physical status, as apart from his medical status, which we've done, hypertension and osteoarthritis, there are three important aspects. One is his vision, one is his hearing, and one is what we call his ability to move or his risk for a very, very important part of geriatric medicine, which is the risk for fall. So, if we were to assess these three things, we would be assessing his physical status. So, taking them one at a time, his vision. Now, vision, all of you know, is assessed as visual acuity. What is his visual acuity or his best vision measured from a 6-meter distance using a Snellen's chart or an E-chart. So if we find a problem with his visual acuity, that is when we say, let us do a detailed ophthalmic assessment and see if he needs spectacles or some other visual aid. So that's the vision part of it, which at this moment I am not going to demonstrate because that requires visual acuity testing. But even that, at a 6-meter distance, at primary care, we can keep an E-chart and quickly assess to see with the best available correction what is his visual acuity. But let me move on to the next thing, which is assessment of hearing. Now, at primary care, we don't have an ENT clinic. We don't have an audiometry provision. Is there any way in which we can screen his hearing? There is. And we present to you two things. One is what we call the whisper test. And one is called what is called the screening version of the HHIE, or the Hearing Handicap Inventory for the elderly. Of these two, allow me to demonstrate to you how we do the whisper test, which is a simple screening device for older people. What do? We test 1 ear at a time. We ask the patient to gently occlude the other ear. Suppose I'm testing this ear, we will occlude the left ear and keep the right ear open. I will stand 2 feet behind from the unoccluded ear, and I will whisper 3 to 6 words, and I will ask the patient to repeat those words. If he can hear, he should be able to hear my whisper. And in order for us to standardize the volume of the whisper, because like you know, we can even whisper very loudly at times. In order to standardize that, we say exhale and then whisper, so that all our whispers are sort of the same level. Now, if he is able to repeat at least 3 out of 6 words that I whisper, he has passed the test, which means that his hearing is kind of okay. And this has a sensitivity of almost 90 to 100% and a specificity of 70 to 87%, which means false positivity is higher than false negativity. Alright? So now, I'm going to do it with him. Let's see what happens. I am speaking to him without the mic because I need to test his hearing. Right? When I speak like this, can you hear me at the back? So, I'm going to explain to him what I'm going to do, and then I'm going to do it. So, Mr. Mike. I'm standing at a 2 feet distance, I'm bending down, I'm exhaling, and I'm now going to whisper 4 to 6 words. So as you saw, I said 6 words. On the right hand side, he could repeat 4 out of 6 correctly, and on the left hand side, he could repeat all 6 correctly. In both cases, he has passed the test. Right? So his hearing, as assessed by the whisper test, seems to be adequate for his functional status. Is that clear? Right? Do you think this can be done at a primary care clinic? I certainly do think so. This is not rocket science. It's not difficult. I didn't need any aid. I don't need expensive equipment. All I need is to get up from my desk, cross over to him, speak to him, and then do the test. And many times we are reluctant to get up from our desks. Right? So testing like this requires us to get up a bit and move around ourselves. Right? So this is the whisper test for checking the assessment of hearing. So vision, hearing. Now mobility and risk for fall. We have 2 or 3 tests that we can do. One is the simplest of them, arguably, is the TGUG, or the timed get up and go test. The second and third, the falls risk assessment, is a tool which has a scale which we mark. And the tandem stand test, as it may, the word itself suggests, requires people to stand in tandem. That means they require to stand with the toe of one foot behind the heel of the other. Even I have to hold this when I do it. Right? It's not easy. And you need to stand like this and see whether the person can balance himself on a tandem stand. Right? That's called the tandem testing. But I'm not going to do the falls risk assessment tool.